Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's program is a special collaboration between MGH Equity and Community Health and Blum Center. Before we get started, just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, the co-host, and our guest speakers will see your questions. Please do not share any personal medical questions or information in the chat box. If you have a personal medical question, please ask your doctor. All right, so next I am going to hand it over to Natalie Johnson. She is the Administrative Director for MGH Equity and Community Health, and she has a few words she'd like to share, as well as introduce you to today's guest speakers.
Thanks, Amy, and thank you everybody for joining us today for this wonderful first part of our conversation. So today we will have Doctors Carine Davila and Gladys Pachas sharing some more information with us about COVID-19 and the impacts that it's had on our communities. Dr. Davila is a palliative care physician at MGH. She received her medical degree from the Icahn School of Medicine at Mount Sinai, completed residency in internal medicine at the University of California, San Francisco, and fellowship at the Harvard Interprofessional Palliative Care Fellowship, and served as a Commonwealth Fund Fellow in Minority Health Policy with Harvard Medical School. She's passionate about palliative care for marginalized populations and has a particular interest in improving care for Spanish-speaking patients. She's active in the division's diversity, equity, and inclusion initiatives and in Mass General Brigham's United Against Racism efforts to reduce disparities in serious illness care for marginalized communities. Dr. Pachas is the program director at the Mass General Center for Addiction Medicine and the medical liaison for community outreach and an addiction medicine researcher. She has served as the co-investigator and project director of several studies conducted at the Center for Addiction Medicine, including novel pharmacotherapeutic interventions for smoking cessation and relapse prevention in smokers with and without psychiatric comorbidities, as well as studies on the effect of marijuana. Together with the Equity and Community Health Group, she has been working on improving COVID-19 testing and addressing vaccination hesitancy among vulnerable populations. So thank you again to Drs. Pachas and Davila for joining us today, and I turn it over to you to impart your words on us. Thank you.
Thank you so much, Natalie. Wonderful. We're delighted to be with you all today, as Natalie and Amy mentioned, to discuss some COVID-19 challenges, opportunities, and lessons learned. So just to review our agenda for today, first, we'll be discussing the impact of COVID-19 on American Latinx and Black communities. Next, we'll speak about the value of language concordant care. Next, we'll discuss a little bit about Chelsea, Massachusetts as a case study. And finally, discuss lessons learned and strategies for community engagement around COVID-19. So first, just talking about the impact. We know that COVID-19 has disproportionately impacted the US Latinx and Black communities. Hispanics comprise 19% of the country's population and yet represented 34% of cases of COVID-19 as of June 2020, so early in the pandemic. Next, we are seeing breakdowns by state. So to orient you, the gray bars across the bottom are the proportion of state population that is Hispanic and Latinx, while the blue bars that rise above highlight the proportion of the state's total COVID-19 cases in the Hispanic Latinx population. This is as of May 2020. So now highlighted in red, you can see Massachusetts, for whom specifically the Hispanic Latinx population makes up 12.3% of the total state's population, and yet represented nearly 29% of COVID-19 cases. And what you can see is really this pattern held true for nearly all states across the board, that all of the blue bars are on the whole much higher than the gray bars. And it just demonstrates that the Latinx population bears a disproportionate burden of disease. Now, looking within Massachusetts, each dot here on this plot represents a city or town in Massachusetts. And across the horizontal bar is the COVID case rate, and across the vertical bar is the percent of the population that's residents of color. And really what we can notice in this is we see a pretty direct correlation that towns that have higher proportions of communities of color, like for example, Chelsea, Lawrence, and Brockton, all also had very high rates of COVID-19 case rates. So those are, again, kind of looking at the top right of this box. Now, even more local to Boston, once we started consistently collecting infection rates by race and ethnicity for reporting purposes, there were early trends highlighting the disparate burden that Black and Latinx communities were carrying early on in the pandemic. And for example, on the right, we can see that the different neighborhoods within the city of Boston, and in particular neighborhoods like East Boston, Dorchester, Mattapan, and Hyde Park, you can all see these neighborhoods were in the darker purple. And these neighborhoods are home to more minoritized patients, and in turn had higher rates of COVID-19 compared to the rest of Boston. Now, looking even more locally to our hospital level at Mass General Hospital, we saw similar trends. These figures highlight patients admitted with COVID-19 infection. I'll draw your attention actually to the bottom half first. Historically, the proportion of hospitalized patients that were Spanish speaking is about 6%. That's that black horizontal line that you see at the bottom. Now, over the course of the first few weeks of the pandemic, the proportion of patients admitted with COVID-19 who were Spanish speaking rose. This is this double yellow bar, rose to over 40% by mid-April 2020. Now, looking at the top graph, we can see overall hospitalizations with COVID-19 in blue over the same time period. Again, this is March to April 2020. And as we could see that the blue bar's total number of patients admitted with COVID-19 was really quickly rising, we also similarly saw the proportion that were Spanish speaking, which is in gold, was also rising very quickly. And what we saw was really that the COVID-19 pandemic created new challenges in caring for patients with limited English proficiency. Here we can see some popular media articles of the time highlighting the challenges of both as the patient populations in these hospitals was changing, the need for interpreters often far outstripped the availability of those interpreters, particularly in person. And the fact that the lack of in-person interpreters created challenges with patients' communication, particularly when illness was very serious or around the end of life. Now, as part of Massachusetts General Hospital's COVID-19 response efforts, Equity and Inclusion Leadership partnered with the hospital medicine unit to create the Spanish language care group. So the Center for Diversity and Inclusion sent a staffing call to all known Spanish-speaking physicians across all disciplines and formed this group. these Spanish-speaking doctors lent clinical, cultural, and linguistic competence to daily rounds, family updates, admissions, discharges, informed consent, and really other services. These physicians were available 24/7 and worked with teams on COVID-19 floors, in intensive care units, in emergency rooms at Massachusetts General Hospital, as well as the Boston Hope Field Hospital. And Massachusetts General Hospital also then shared the model with other hospitals both in the area, like Brigham and Women's Hospital, Beth Israel Deaconess, and Boston Medical Center, as well as hospitals further away who were interested, including the Johns Hopkins Hospital in Baltimore, among others. And this is a wonderful slide that really highlights the 51 physicians who represented 13 different departments across the institution and 14 different countries who volunteered as part of this workforce, the Ernesto Gonzalez Spanish Language Care Group. And what we know is that the Spanish language care group's language concordant care really offered an opportunity for a win-win-win situation, something that's not always easy to come by. But really, it was responding to the challenge of the detriment of care that occurs when language becomes an obstacle. And so patients and families were really better served by communicating with someone in their own language. Second, hospital teams were better served by enabled communication and support in critical tasks that this team could offer. And third, members of the Spanish language care group felt fulfilled and energized by doing this incredibly meaningful work. Some, in fact, felt like it was the most meaningful contribution of their careers. Now focusing in on Chelsea for a moment. So the city of Chelsea occupies about 2 square miles north of Boston. It has some of the most densely populated neighborhoods in the country. It has an estimated formal population of 40,000 residents, but informal estimates claim or suggest that there may actually be up to 75,000 residents in this small town. And about 65% of Chelsea residents are Latino. Many are immigrants from Central America, are undocumented, are low wage and essential workers, live in overcrowded housing, and lack access to healthcare and social services. Now to orient you to this slide, here we can see Chelsea cases in red, Revere in yellow, Suffolk County in green, and the state of Massachusetts in blue. What I'll highlight is really focusing in on red in Chelsea. And so for the week of June 10th, 2020, right after the peak in cases, Chelsea had recorded nearly 3,000 cumulative cases at a rate of over 7,500 per 100,000 individuals of population. That was a positive test rate of over 38%. The state, by comparison, had reported 100,000 cases at a rate of only 1,400 per 100,000 with a positive testing rate of 15%. So that suggests, I know that's lots of numbers, but really during this time, Chelsea had a COVID-19 infection rate over 5 times higher than the state average. And many of those tested were positive, indicating relatively low access to testing when the positivity rate is so high, and also just reflects a really high burden of disease. And soon, the academic literature began to be filled with a body of research highlighting the significant healthcare disparities that really manifested during the pandemic. Our healthcare system lacked a firm foundation for caring for and meeting the needs of minoritized communities. And then, once facing the severe stress of the pandemic, cracks in the foundation became more apparent. The racial and ethnic disparities were really staggering, which I hope you can appreciate with some of the figures that I just shared, but really staggering across the board for Blacks, Latinx, American Indian, Alaskan Natives. And so what we saw was that there were really four main contributors creating a perfect storm that was affecting racial and ethnic minoritized groups during COVID-19. So let me walk you through. First, there were challenges with healthcare access and utilization. We know that the Latinx population has the highest uninsured rates in the country at 17.8%. compared to 5.9%, so 3 times that for non-Hispanic whites. We know that non-citizens do not have access to services such as Section 8 housing, Medicare and SNAP benefits, food stamps, etc., healthcare facilities, and others. And overall, the Latinx are really disproportionately affected by discrimination in the healthcare systems, and they have overall distrust in the government and systems. We know that they're disproportionately affected by non-communicable diseases, including diabetes, hypertension, renal and liver disease, heart disease, and obesity. And lastly, nearly over a third of positive cases have no symptoms, and so it makes us underestimate often the number of cases. Next, income, housing, and wealth gaps prior to the pandemic also really contributed to this storm. We know that many Latinx individuals work low-wage jobs and have less financial security and ability and capacity to make healthy decisions. There was much food and job insecurity, given that many in this population work in service industries that really disappeared during the pandemic, skyrocketing unemployment rates. And in terms of housing, they often lived in overcrowded spaces and in multi-generational homes, increasing the risk of exposure. Next, highlighting a few more things in terms of occupation. As I mentioned, Latinx workers were much more likely to work in low-wage jobs. And in 2017, 1 in 5 Latinx workers were really paid poverty wages. But what we know is that a disproportionate percentage of workers in essential industries were from the Latinx population. And so these so-called essential workers had to keep going to work, and that meant, continuing to be exposed or at risk for infection. And if they were sick, they were often not working in jobs that permitted remote work or even sick leave. So they were forced to make really difficult decisions if they couldn't even afford to take a sick day, or if knowing that they had to take a sick day made them worried about how they were going to access the things that they needed. And lastly, there was a lot of communication and cultural gaps. For example, there's, as we know, a higher proportion of Latinx individuals have limited English proficiency. There's overall kind of mistrust in healthcare institutions that resulted in a lack of what they perceived as credible COVID-19 information. And finally, cultural differences between patients and providers. So all of this together, as I mentioned, made a perfect storm and particular challenges for minoritized communities during the pandemic. So now we'll transition to lessons learned and discuss some strategies for community engagement around COVID-19. So with that, I'd like to pass it to Dr. Pachas.
Thanks, Carine. As we know, the COVID-19 pandemic has certainly created many challenges as a consequence of these inequities in our community. Among these many challenges, I'm going to present 2 of them. The first one is testing, getting tested. And as we know, increased access to COVID-19 testing can help slow down the spread of the virus, but it is not, as we learned, it is not as simple as just telling people to get tested. There are different barriers, there are different circumstances. For example, in April 2020, investigators found that the median travel time to a COVID-19 testing site was about 20 minutes. And they also found that places with a travel time that was longer than 20 minutes had higher percentage of racial and ethnic minority groups who were also uninsured. A different study also included factors such as lack of insurance, concerns about the cost or co-pays of the testing, occupational reasons like it was mentioned before, such as not being able to take time off work or lack of paid leave, and also lack of accessible options for people with disabilities and lack of trust in the healthcare system. Most recently, a report done by the Massachusetts Department of Public Health in 2021 described the top reasons for not being tested as one, the individual who had symptoms didn't know they met criteria for testing. They thought it didn't apply to them. They didn't know where to go when they wanted to get one. They didn't know they had been exposed. They only had mild symptoms, so they thought it wasn't COVID, and testing was too expensive. And also when test was not available when they wanted or needed the test. Next, please. The second challenge is vaccination, vaccine hesitation. And we were all excited about, developing the vaccine that came very quickly, and we were so hopeful, but then soon we learned that there was a lot of people who didn't want to get vaccinated for different reasons. We found that among the reasons or misconceptions that make people hesitate were trust. For example, there is historically, there is medical malpractice in the Black community. We have big pharma, so people think that there is a lot of involvement in big pharma trying to make money out of vaccines. They're worried about or fearful of catching the virus again, or as we learn, the DNA changes that can produce the vaccine. They also think that the vaccines were approved too quickly. There is a need for further research so they can prove that the vaccine is really safe. And also they were seeing that people who got vaccinated, they were still getting cases, and they thought, why I'm gonna get the vaccine if I still get cases? There are also the group of people who got the vaccine, but didn't want to get the booster because they thought it was enough. They also were worried about different variants, and also the side effects. That people saw that some people getting the vaccine, they were in a lot of pain, or they had some fevers, they didn't feel well, so they thought that they didn't want to get the vaccine just because of the side effects. Next. So what to do about these inequities? We have the COVID Equitable vaccine plan that focus on diverse individuals who have limited access to technology, had limited English proficiency, or have immigration concerns, or have mistrust on the healthcare system. The first goal is to increase awareness, and awareness of vaccination efforts that include the vaccine, things like where the vaccine is available, how can we schedule a vaccination. The second goal is facilitate administration of the vaccine in the community. And the third goal will be to address vaccine hesitancy and misinformation by bringing trusted messengers to the community to answer questions and address mistrust in the community. As you notice here, I capitalized the word community because engaging the community is really a crucial aspect of the plan. Next. So how do we engage the community? By building trust through a genuine and real partnership with the community and their institutions. We had a really good example with La Colaborativa in Chelsea. We have examples with churches. Another strategy is increasing access and empowering communities. And the goal really is to give people the tools to make their own health decisions based on scientific evidence and not on fear or misinformation. And another goal would be dissemination of information that is truthful and accessible. We needed to debunk some misinformation, identify sources of misinformation, and really having patient-centered conversations with people in the community. Next. Next, please. So we needed a team, right? And we had really people coming from different groups. They came together. We had the equity and community group. We had the MGV community cares team. We have the Craft Center for Community Health. And we also have the community messengers. And this group is a multidisciplinary, multicultural, multilingual, mouthful, group of over 150 clinicians, fluent in 20 different languages across the MGB system, who volunteer their time to organize and attend some community events to really provide clinical expertise and discuss all the health information with the community members, and to really answer questions and to really seeking an authentic engagement and partnership with community members. To do that, community messengers use different strategies. The first one is video testimonials, in which clinicians with expertise with COVID-19 recorded videos in different languages addressing different topics like COVID-19 prevention, like washing hands or social distancing, or how to use a mask. They also had videos addressing vaccine hesitancy, how to addressing myth and facts, and most recently, how to run a home test for COVID-19. We also had online community event webinars. Clinicians host COVID-19 information sessions with the community and organizations. We had groups like Latinas Know Your Rights, churches, live sessions and discussions with different social media with El Planeta, Univision, Java with Jimmy. We also had in-person community outreach, whether it was with the van and vaccination sites or testing sites. We really assisted, or community messengers assisted in answering COVID-19 related questions, administered surveys, trying to collect information from the community about their needs, and also discussing all the health information with the community. We also had one-on-one discussions. It was just only in a group. If someone wanted to talk with a community messengers, we had discussions with them, talk about patients and peers about questions and concerns. And we also had Q&A sessions for incarcerated individuals in Massachusetts jails. Next, please. So that was our team, right? But now we need allies, and our allies were the community. So we partnered with organizations that responded to community needs and addressed the social determinants of health. We partnered, for example, like I mentioned before, with La Colaborativa, which is a nonprofit that supports Latinx immigrants in the greater Boston. Their headquarters is in Chelsea, but they also work with people in East Boston, Everett, and other places. We also partner with organizations such as Roxbury Main Streets and Nubian Square, which is really a vibrant and inclusive commercial district that supports local and minority businesses. And also, we also partner with the Black Boston COVID-19 Coalition, which is a group of organizations and people from the Black community who have come together to collaborate information and resources during the COVID-19 pandemic. Next, please. Next, please. We also partnered with communication and social media organizations. We had this incredible opportunity to work with El Planeta, El Mundo, Univision, which are Latinx networks, work with Java with Jimmy, and do presentations like addressing hot topics like testing, social distancing, masking, vaccination. Next, please. And as part of our partnership with the community, we also, and this was, I think, the most exciting thing, we also participated and supported events organized by different groups and coalitions in the community. We had, for example, the National Vaccination Day, in which MGB was present. We have the Roxbury Unit Parade. We had the events for Pride. So with the goal really of getting close to the community, bringing information, testing, vaccination, or whatever else was needed. Next, please. So we have our team, we have our allies, now the strategy. First, the mobile community cares team. The COVID mobile response started in January 2021 with 4 vans offering testing services. And then when vaccines came about, vaccination happened. In general, there were 2 teams. The first team was the engagement team van who dedicated efforts on giving COVID-19 information and education, really. Distribution of care kits and other resources. Multilingual community messengers participated in these events. They hosted and supported all the community events and also some education and development of flyers with COVID-19 information. The second team was the mobile care van, and they were in charge of COVID-19 testing, vaccination, and giving resources. We had, as part of this team, on-site multilingual clinicians and community resources specialists that were able to at least try to answer questions that the community had, not just about COVID-19 in terms of health, but also all the consequences of COVID-19, such as unemployment, housing, and other problems, and also voter registration. Next, please. So I'm a researcher, so I love numbers. And here we have some numbers about the things that we did. The first thing is the community engagement, education, and care kits. So you can see here, we participated in 113 community outreach events and collaborations, providing education and resources. We, for example, supported the Black Joy Day, the Roxbury Unity Parade, as I said before, and many others. And what we did really was to bring the MGB presence, place our table on the street right next to a very crowded area and connect with the people. We distributed over 35,000 care kits that had masks and hand sanitizing. We had all the resources depending on the community. We had baby baskets, we had school supplies, hygiene products. We have over 100 MGB providers and community messengers that were engaged in outreach, canvassing, knocking doors, going to restaurants, providing care kits and education in Boston neighborhoods like Chelsea, Everett, and others. Really being close to the community, being close to the people, talking with them and connecting. Next, please. In terms of COVID testing, we ran almost 7,000 tests in 6 different hotspot cities during that time, with a large percentage of racial and ethnic minorities. Next, please. Something else that we did was food distribution, and that depending on the community and the coordination with different institutions. So we were able to distribute hot meals every Friday in Boston communities, also provided food delivery to families and organizations in Chelsea and Revere, and really in coordination with organizations in the city. Next, please. In terms of the COVID vaccination, we really were able to vaccinate over 13,000 people from June to the end of October, beginning of November, with a high percentage of Latinx individuals. So the mobile vaccination effort happened in collaboration really with cities, with food pantries, for churches and other community partners in different places like Dorchester, Jamaica Plain, Roxbury, Hyde Park, Chelsea, and Salem, Peabody, and other places. Next, please. Something that we learned early on, and as Carine said before, so we learned this, especially with the Spanish language care group, was about the importance of having effective, accessible, and timely information. So as part of the mobile education and vaccination efforts, The team developed a multilingual, accessible, timely, and audience-appropriate flyers and information, printed information that were given to people and discussed with them in their own language. We have them in Spanish, Haitian Creole, Russian, Portuguese, so different languages depending on the community, to really be able to present the information in an appropriate manner. So building relationships with the community needs to enable a bi-directional communication and learning, right? We go to the community, give the information, education, but we also it has to be bi-directional. We need to get information from the community, from their needs. We need to listen what they're saying. So if you ask, they tell you what they need. And so part of the information we collected in those surveys that we did was, for example, that they wanted more access to testing and vaccination. So there was a group that thought that it wasn't not accessible. They needed more information in terms of testing and vaccination, information on resources, because things back then changed too quickly and they couldn't keep up with the change in regulation and information. Resources for mental health, and that was very important for us to know that they were asking for access to therapy, to mental health treatment and support, and also for domestic violence advocacy. They also were worried about lack of access and increasing price of food and groceries. And also were worried about those families with financial hardships that were struggling to finally recover after the pandemic. They were requesting more flu shots, more hygiene products, housing support, and other needs. Next, please. So as we heard before, Chelsea was a hotspot, right? The COVID-19 infection case rate in Chelsea was over 5 times the state rate. But I love this slide. As of March 2022, 92% of Chelsea's eligible population is fully vaccinated and 46% receive a booster. And this is awesome. And this is part or really a consequence of the effort that it wasn't just MGB, it was really community-wide. Organizations all across Chelsea got together, played together, and really achieved this. Of course, I'm mindful that in these statistics, we don't have the people who are not who are illegal immigrants that are not counted here, unfortunately. But it gave us hope, right, to see that after the work that we had for the past few months, we achieved this. Next, please. Some take-home points. We have that across Massachusetts, racial and ethnic minorities experience much higher rates of COVID-19 cases as presented by Carine. The state's 5 communities with highest COVID-19 rates are all majority minority, including Chelsea. The Spanish language care group is innovation born out of necessity to support a significant increase of Spanish-speaking patients with COVID-19. And this is something that we learned, that using a multilingual approach with accessible options, tailored community engagement, and use of non-traditional models of communication really help reduce some disparities. And finally, it's important to give the community the tools to make their own health decisions based on scientific evidence, not on fear or misinformation. Finally, acknowledgements. We really wouldn't be able to talk about all these things if it wasn't because of these groups here: the MGB Community Care Team, the MGB Equity and Community Health, the Craft Center for Community Health, the Ernesto Gonzalez Spanish Language Care Group, which I'm part of and so proud being part of, and all the people that we're not mentioning here, organizations in the community like La Colaborativa and others, churches that work together with across the city. So thank you so much, and here we are for questions.
Thank you so much. We are now at the end of the session, so if you have any questions for Dr. Pachas, Dr. Davila, feel free to enter them in the chat box. So we have a question about current challenges. Now that everything is starting to open up in our communities, such as lifting of mask mandates, not needing proof of vaccination to enter public places, what new challenges are you currently seeing and how are we addressing them?
I can take that. I think one of the challenges is to keep going, right? To keep the presence in the community going, not because COVID-19 is turning from a pandemic to an endemic situation. That doesn't mean that the community doesn't have other health problems. And one important thing to address now is to bring people who didn't come to the hospital for regular care to come to the hospital for care, to come to their primary care physicians for screening like mammograms or PAP or other screenings. So to keep connected with the community, keep working with them. And like right now, one of the things that we want to address is bringing the community back to their physicians.
And I think I'll add, I think a second part of that question is also around, norms are changing. And as COVID cases are kind of rising and falling with these new variants, this is now, to some degree, a new normal. And how do we adjust to that? And I think you're right. I'm a public health minded individual. And so I'm always somebody who kind of will advocate that if, cases rise again, that perhaps we should reinstitute some of these broader public health measures. And while, we kind of wait for, our city, Boston Public Health Commission or state recommendations or school recommendations or things like that, I think each individual and family should do the best that they can with the information that they have to make personal decisions, for example, about whether or not they wish to continue wearing masks. We know that there were many people who were wearing masks on airplanes long before the pandemic. And so, that can continue and, may continue for some. And so I think it's important for all of us to make our own decisions and also respect that there are kind of others more vulnerable than us in the community and to kind of do the best that we can. But there's no easy answer. I'll just name.
Thank you. Can you talk a little bit more about second boosters and when it's best to get the next one?
So I think, again, this is one space where there's no clear-cut answer. I think the FDA recently approved a second booster for more broadly for individuals and kind of just recommended that it occur, at least 6 months after the prior booster. And so for some, that may already be kind of coming up soon. And so there's no right or wrong answer. I would say it's perfectly reasonable to go ahead and get a second booster as soon as you're eligible. And for others, they may want to wait a little longer. I think the discussion about second boosters is a reasonable discussion to have. And I want to make sure that we're focusing our energy on what's moving the needle more, which is actually really making sure that all the people who haven't gotten their first booster really focus on getting that. And so, even in the wonderful numbers that Dr. Pachas shared of, Chelsea's high vaccination rates of over 90% are fully vaccinated. If you didn't catch, it was actually only 40%, 46% at that point in time had gotten their first booster. And so I think it's really important, and what we really want to encourage is to, continue to talking individuals, continue underscoring the importance of getting the first booster even before we talk about the second, because we know that the protection really increases with the first booster. And yes, I do think that the protection increases with the second booster to a degree, but it's not as big. It's not as big a bang for our buck as getting the first booster. So I think the first place is to really encourage people to make sure that, of course, not only fully vaccinated, but getting their first booster.
I will say stay informed, right? Really analyze where you're getting your information from and be up to date, right? Things change all the time. The second booster came out. It was only for, I think it was for 60 and up, and then that changed for everybody. So regulations and norms change. So let's stay informed from trustful sources.
Thank you. If there are still people within our community who are hesitant to get the vaccine at this point, what are your suggestions for speaking to them in a culturally competent way?
You want to go?
So I'm happy. I think, first of all, just share, I think there's, I think the first place to start is always being curious and asking questions and being respectful that, as Dr. Pachas said, that everyone is kind of entitled to make their own health decisions. And hesitancy isn't a permanent state of being. And there's still people who are getting their first vaccine now. And that is really exciting. And it may be that they've been kind of hesitant for a while, or it may be that somebody started to explore, or it may be that they're getting different information from different sources. So I would say, I think for no matter who you're speaking to, of whatever racial or ethnic or other identity background that they're from, even if it's different from yours, always start with curiosity and ask them to share, how are you feeling about the vaccine? What makes you nervous? And giving people an opportunity and space, and doing so authentically in a way that's actually genuinely listening to them and not dismissing them as someone who has different feelings or isn't believing science or anything like that. I think the moment that you are only speaking superficially is the very moment that they'll shut down and not be willing to engage in an honest conversation with you. So I think being genuinely curious and taking the time to listen to what they have to say, and not immediately going to a place of rebuttal of like, well, that's not true, well, this isn't different, or anything like that. Just explore.
I will say, I agree with what Carine said. I will say, like, to me, there are three very important things. One is transparency, right? Communicate facts and knowledge. According to my experience, many times when people have the facts, they understand what the risks are and how important getting the vaccine is, and use the power of storytelling, right? Tell stories, tell your own story if you want, share your own experience about your vaccination and your doubts, and how the process of changing all throughout this COVID-19 period happened, what your experience with other people, that people appreciate. Being humble, humility, recognize that we need to work really to gain people's trust first. And then it's okay to say, you're right, I'm gonna check on that, I'll come back to you. It's okay to say we don't have the answers because we don't know, we're not perfect, we don't have all the information with us. And it's okay to say, yes, respectfully, I don't know, I'm gonna come back to you. And empathy. And I think that's going back to what Carine said, think how previous experiences influence their decisions, right? Maybe they had something in the past, maybe they had an adverse event to another vaccine, maybe they saw something with somebody else that had a bad experience and now they don't want to do it. And also, again, that we are on this together. It's this public health situation, and it's thinking in a communal way. But I think transparency, being humble and humility, and be very empathetic, respectful of cultural differences. One thing that I didn't touch upon is the religious aspect of it, that the vaccination, I heard this many times, is, God had helped me so far, God had taken care of me so far, I don't need a vaccination. And there were very interesting discussions with that, but there are many other cases that we can spend the entire day talking about.
And I just want to underscore something that Gladys mentioned specifically, and even in this presentation, we talk about the idea of kind of trust and mistrust. And I think sometimes too often we can blame individuals from the communities. Well, they don't have trust in us, or they have mistrust, where really that's not the problem. I think the problem is historically, we as institutions and systems and in healthcare have historically not given people from minoritized communities, have not demonstrated trustworthy behaviors. And really the onus is kind of on us as clinicians, as people working in the system. I've done some research that really kind of provides a framework that's like every single opportunity and interaction for someone is an opportunity to have a trust building or a trust eroding experience. And so it's not just about, the minutes in the room with a clinician. It's really every single person, from the person who greets them at the door to give them a visitor pass or a patient pass, from calling to an appointment, from getting their vitals checked to seeing a clinician. Every single person in that chain is important. And we want to collectively do better to show our patients respect, listen empathically to what's going on with them, so that we can be building more and more of these trust building experiences to demonstrate and do what we can to earn our patients' and families' trust.
Mm-hmm. Touching upon trust also, in building trust with the community is something important. Is in the past, it happened many times that we go to community, do whatever we needed to do in terms of research, but we didn't stay in the community. We didn't identify with them. We didn't work together towards something. And I think that is another important thing that we need to do. That is another, it's some of the COVID measures have been lifted. There are other things that we can work with the community, that we can come back to them, and not just because COVID passed, we're going to go back to the hospital and be in the office, right? We need to stay with them. And I think that is an important aspect of building trust with the community, as we are here to work together, not just because I need something from you. On the contrary, well, I'm getting confused. Not just because I need something from you, it's because we need each other, right? And I think that is an important message to that our presence in the community should stay there. No, we shouldn't just move back and forth when we need something from them.
Thank you. As we think about minority health, are there suggestions on navigating continue to still wear a mask, social distancing, etc., especially for children in school?
So you were breaking up. Can you repeat the question? I'm so sorry.
Of course. As we think about minority health, do you have any suggestions on navigating continue to still wear a mask, social distancing, among others, especially for children in school?
Mm-hmm. I think, and one of the recommendations of the CDC, or at least the one that they had, was to make sure to know the rate of infection in your community, right? If your rate of infection is very high, it really recommended to still use a mask. If your rate of infection is low, then it can be optional. People, if they still want to wear a mask, that's totally optional, and they are totally allowed to do it. Also, be aware of and be honest with yourself in terms of symptoms. And there are people who have symptoms that still go to work because it can be COVID. So another important aspect is also, be honest with yourself in terms of symptoms.
I think the other piece is just to underscore what Gladys was mentioning in terms of knowing your infection rate. Also, I think there's some information that's put out there that is also not even always very clear from even really wonderful bodies of information. So for example, I know the CDC highlights, I think it's by county level, for example, like red light, yellow light, green light. And I think you just have to be very careful with measures like that, because sometimes they reflect infection rate, but sometimes it actually reflects a different measure, which is, for example, if you were to become ill, would there be enough hospital beds? or ICU beds to care for you. And so we may be in a position soon, if variants are getting less severe, where infection may be really high, but it's not necessarily overwhelming our hospitals. And so there may be a kind of green light of, yeah, there'll be a hospital bed available for you, but that may not necessarily reflect that the infection rates are still high. So you just have to be really careful. And I encourage everyone to kind of have a very critical eye when you're looking at any measures to get a sense of your local infection rate.
And also those measures change every week. So whatever you saw 2 weeks ago, it's probably changed.
Thank you so much. So I think we are almost out of time, but before we end today's session, I did want to mention that we are hosting a part 2 session within the series. So mark your calendars on Wednesday, April 27th at 1 p.m. So I know usually our webinars are at noon, but this program will be at 1 p.m. where we'll be presenting on COVID-19 moving forward and returning to a new normal. So stay tuned, more details to follow on that. And Dr. Pachas, Dr. Davila, thank you so much for a wonderful presentation. Everyone, thank you so much for taking the time to join us. As I had mentioned, today's session is being recorded. So if you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.